Hello, everyone. Welcome to this class about healing birth trauma during COVID pandemic. My name is Ibone Olza. Many of you already know me. I'm a medical doctor and a child and infant psychiatrist, and I currently direct the European Institute of Perinatal Mental Health in Madrid, Spain. Let me explain you a bit about where this workshop comes from. At our institute, we are offering a training on perinatal mental health, and within that training we had this month a seminar on the psychopathological aspects of childbirth, where we covered all these topics. We talked about birth interventions and the consequences they have on the birth experience. We talk about traumatic birth, about perinatal neurobiological changes. We talk about the detection of and symptoms of birth trauma. We also talked about obstetric violence and the relationship it has with traumatic birth experience. And then my coworker, Cristina Cortez, who's a psychologist specialized in traumatic therapies, covered the topic of psychotherapy for perinatal birth trauma. So in that context, we had this extra class about healing birth trauma during pandemic COVID, and we did that class in Spanish, free, online, open access, okay? And now that was the first class we did in April, where we cover the aspects of coronavirus infection in the context of pregnancy, childbirth, and puerperium. So this second class, which is the first one I offer in English, will be more focused on how to heal birth trauma. And just to introduce this topic, this is one of the very few papers that has come out in these past 2 months. You know, there's been this surge of scientific papers, but this one's one of the very few ones that actually name maternal mental health needs in the time of the COVID pandemic, and that's why I want to introduce some of the ideas that Theba and colleagues mentioned in that paper that was published in May. They talk about how these strict public health measures that we're having to implement everywhere, they obviously mitigate the spread of the disease, but they also, we know they cause negative psychological effects leading to stress, anger, and confusion. And how this also the economical consequences of this pandemic will probably further escalate the psychological burden and worsen the mental well-being of pregnant women and new mothers. And that's why it's important to talk about maternal and infant mental health in this time of pandemic. And we know that unfortunately some individuals might resort to harmful methods of coping with the crisis, like substance abuse or alcohol, or even what really worries us working with pregnant women is gender-based intimate partner violence. That's really worrisome, and we know that's probably might be getting worse in many contexts with the isolation and the confinement. So we're very worried about this. And as these authors mentioned, mental health needs are currently overshadowed by other more pressing issues in healthcare. And even though this might be completely understandable, we think it's very important to put this in the front light. And as I said, there are many pregnant women that are now at increased risk of depression, anxiety, and post-traumatic stress symptoms. And we know, we well know, all of us working in the maternal mental health field well know that this might have long-term consequences on the infant mental health in the long term, and also on the partner, in the couple relationship, in the whole family. So really, we are very aware that how the mother goes through the pregnancy, how her mental health is in the postpartum as well, is very important. It's important for the whole family, and I would also say for the whole society. So these authors also mentioned this, that there seems to be a reluctance to accept this, that the psychological well-being of pregnant women is important to care. But we do think it's important, and we agree with these authors that they say we should develop appropriate strategies to alleviate the stress and proactively. And of course, there could be many tools, internet-based, many of them, virtual online consultations, web-based psychological support, therapeutic interventions. And we feel this class that is originally in Spanish, but now we're doing in English, it's also our goal to offer this knowledge, to share it, so it can help many of these women and their families, and also the professionals serving them, understand a bit better what birth trauma is about and how we can heal it in this context. Last 2 weeks ago, we celebrated Maternal Mental Health Week. And in our institute, we came up with this campaign that said, "You're not a bad mother." That we think this is a very important campaign to alleviate and mitigate the stigma that still surrounds maternal mental illness, and we really want to work in this direction. Okay, so let's get into our topic today. What do we mean by when we say what does healing birth mean? What is a traumatic birth? Well, that's a big question. We're working on that now, many of us. But I would start by saying that the emotional wound that a birth can leave is subjective. It's not something we can see or measure from the outside. It's the woman's experience that it's important. Okay, it's her experience during birth might be traumatic for her, but it can also be traumatic for the infant, for the father, or for the female partner, if there is one, and also for the family. And very important not to forget that healthcare providers might also be traumatized by the birth. And we know also, it's clear now that the experience of birth changes over time. And that change might be positive because it might be influenced by the support and the care the women receive postpartum. That's why it's very important. So the effects and the consequences of traumatic birth are not visible, as I said, but they do have a great impact on the physical and mental health of the whole family. And just to remind you a bit of important things. Birth, we now know it's a neurohormonal event. We know that it's probably the baby that gives the signal that's ready to be born, to come out. And all through birth, there's a delicate dialogue between the maternal brain and the baby's brain as the baby goes through the birth channel. I always call them babies, even if they're in uterus. Okay, I don't like the word fetuses, so I will talk about babies even if I'm referring to the baby in the womb. Okay, but I strongly recommend you this report by Sarah Buckley that review all the hormonal physiology of childbearing and what implications this has for maternity care. And there's a lot of studies now that have summarized the effects of oxytocin as the main hormone during labor and how important it is to promote oxytocin during birth and also in postpartum. Okay, and we also carry this little research on the psychological experience of physiological childbirth, and we published this a couple of years ago, and we found that giving birth it really is a very intense, transformative psychological experience. And when things go well, women come out of birth feeling empowered, and we feel there's probably a profound reason for this. Okay, for birth to be an empowering journey, a transformation, and it's important to know it's supposed to be like this. So just to remind you, birth is a neurohormonal process that comes with an altered state of consciousness in the mother, and that has many implications for the way we care for laboring women and for the family. So now I will talk about birth trauma from our perspective. We work within this ecosystemic model that we drew from Uri Bronfenbrenner and also from John Bowlesby attachment theory, but we work in this ecosystemic model where we see birth trauma in this perspective. We try to approach the wound of birth trauma. And in our look, when we regard this topic, we try to work with, as I say, with the skin and the body, okay? We try to, for us, this is like a type of work that implies that we, the therapist, also put our skin in the relationship. And these are difficult things nowadays with all this coronavirus pandemic. But we will try to put things into words, and we try to be very careful with each word. And for us, the main thing is care. And to care properly, we have to respect everybody's own rhythms, the woman's rhythms, the baby's rhythms, and also our own rhythms. And we will try to contain when we can. We try to flow as things come. And for us, learning and working in this psychotherapeutic model, it's also about healing ourselves about learning, about deconstructing some of the things that we were taught that are no longer valid, and we try to enjoy this as much as we can. So just briefly, I will get into what we mean when we talk about this ecosystemic perspective that, as I said, was developed by Uri Brenner back in the 70s. And he talked about developing a model of developmental psychology that was ecologically valid. And that implies seeing the forest, not only the tree. And I think this is very important today in the midst of this pandemia. Okay, we really have to keep our eyes wide open and try to see everything that's going around each family we work with, around the mother and the baby, but also the system. And we have to put the focus on prevention and care, and that's why it's very important that we work multidisciplinary and we do early interventions. And Brenner talk about these levels, okay? So if we apply this to the perinatal mental health field, we will see at the microsystem, we might have the neurobiology of attachment that we now know well, the epigenetics, the impact of toxic stress on the baby's development, all this knowledge that's very, I would say, very biomolecularly grounded. But then we have the mesosystem, and we have the maternal and paternal psychology, the family dynamics and how that interferes, and we have the intergenerational transmission of attachment, and then we have to see the relationship between all these systems, between the extended family, the health system, the work system, and all of these within the culture. And the culture dictates also certain roles that have a heavy weight, especially when a baby is born. And we try to do this. For us, it's very important. We carry a gender perspective because it's very important to understand the violence many women suffer, and we really think it's important to try to have, as I say, a broad look. And of course, the chronosystem. So this has been in the news. This is our news from Spain, but you've probably seen this in your countries. The effect the pandemic is having in our lifestyles is affecting a lot also the pregnant women. This was in a Spanish newspaper. It was an interview of pregnant women and recent mothers, and they would tell things like how they had to move away from people on the street, and these big worries and these big fears of contamination. So in the context of this pandemic, how are we going to treat birth trauma? We have to see what the context implies. This context of pandemic implies a lot of uncertainty, a lot of fear, plus the situation of confinement, separation, isolation. We've seen the protocols of maternity care changing quickly, and we are very worried that COVID right now implies high risk of obstetric violence. We've seen this in Spain, we've seen this in other South American countries, and there's more and more evidence on this. This is a report published by Human Rights in Childbirth on May 6th, I think, and they describe this, how this change in protocols is not always based on scientific evidence, and it's not, sometimes it goes against the practices endorsed by the World Health Organization. And many of these changes are arguably unnecessary and even harmful. And in their report, they published this report in the website, and I recommend all of you to read it. I think it's very important. They describe different ways of mistreatment and human rights violations, what we call obstetric violence in maternity care during this pandemic. We've seen women being denied the right to a companion during labor and birth. We've seen women being required to use interventions in childbirth, women subjected to forced inductions and cesarean sections without medical indication. This is very, very serious. Mothers and babies are separated from the infants and discouraged from breastfeeding with no evidence whatsoever. So far, up to date, we know that probably coronavirus does not cross the placenta. Probably there's no vertical transmission. And current recommendations are that even if the mother is COVID positive, she can breastfeed her baby. Okay, as long as she follows this care of contact. So, and we've seen also how maternity staff have not been provided with adequate personal protective equipment and other essential resources, and this is very serious. We've seen in Spain, unfortunately, we've seen many healthcare professionals have died. And we've seen this in other countries too because of lack of equipment, and this is very serious, and it probably adds to this context, okay? We've seen how in many places maternity care staff has been redeployed to other units, leaving maternity service underserviced. We've seen the centralized community and out-of-hospital maternity services being limited or closed, and this affects especially the care of women from marginalized groups. So there are many consequences of this containment and of this context and this change of protocols on maternal health. This is from Spain. In a Basque hospital, this was in a newspaper, a mother was not only allowed to take her newborn in her arms, but her healthy infant was taken away to the intensive care unit with no previous warning or explanation. And this is the mother's words, okay? They acted as if she, the baby, were hospital property and not my daughter. I was taken to a ward for the COVID infected, but I had had no symptoms for more than a week. I could not breastfeed. I was alone in the room. They told me, do your own things, make your bed, clean the room, change your sheets, and put the dirty laundry in this bag. They did not care I had given birth 3 hours ago. They only care about my temperature and whether I had breathing difficulties. That for 3 days. It was the worst nightmare I can imagine for my birth. Totally inhuman and not scientific. Unfortunately, these are birth stories from the beginning of the pandemic in Spain. Things have got better, but it's true that many women have gone through very difficult situations that are not justified. Okay, so what is the context? The context, as I already described, is uncertainty, fear, confinement, separation, high risk of obstetric violence, plus the effect of fear, the toxic effect of fear. And mothers are afraid. Pregnant women are afraid of being infected by COVID. They are infected or afraid of infecting their infants or infecting other family members. But they're also very afraid of being separated from baby and being hospitalized. And they're also worried about having to spend the postpartum in isolation with no support or network. And it's difficult to create networks. Usually in postpartum, you need to bond with other mothers, and nowadays this is more difficult. And this lack of support will make the healing of this birth trauma more difficult, we think. And of course, social media might help in networking and texting, but many women do not have enough access to those resources. So I was thinking about what are the possible scenarios, and I came up with 3 scenarios just to have a global idea of cases, okay? I think this is the most common scenario, okay? Women who are pregnant and who are not infected, and this is the most common scenario, but they are very afraid. They're very afraid, and what this stress might have a toxic effect on the development of the baby because we know so much about the toxic effects of stress during pregnancy and about how that impacts neurodevelopment of the baby. But there are also some positive things about confinement. We've seen that in our country, in Spain, where we have had confinement since the beginning of March, and some pregnant women, thanks to the confinement, have been able to stop, not work, relax, be at home, spend more time bonding with the babies, bonding with their partners or with other children. So it's not all negative. There are some good sides, but still, many women are stressed about their works and how that will affect everything after the pandemic. Pregnant women have been very worried because of the birth stories they've been hearing from other women and what they've been seeing in the news. So they're afraid of suffering unnecessary interventions or suffering unnecessary cesareans. They're very afraid of being separated from their infants after birth, and they're worried about what's going to happen to them. And this is totally understandable in this context, all these worries. So, fortunately, the good news is that we know most pregnant women are not, if they get infected with COVID, they will develop a mild or a mild disease. It's very rare that pregnant women get severe pneumonia by COVID, but it still can happen. But it's fortunately we know it's kind of rare. So this is a story from a woman. She wrote this: "Alone? Am I going to be alone in this terrible situation? Who will call me and support me during the hours of labor?" This is when she found out that her husband would not be allowed in the delivery room, okay? "Alone? My partner will be alone with no news about how I'm doing, without meeting his child from the moment of birth. Who will tell me he has become a father? Yes, if there are no individual rooms, he will have to wait outside on the street. It's unfair. They cancel our prenatal follow-ups, our prenatal classes. We're so alone already. Don't take the support of our partners away too. We need their company in harsh times. They know how to calm us. And don't take the moment from them, meeting their child and supporting their wife's labor. 50% of the baby is me and 50% is him. So we saw this in Spain. At first, partners were not allowed, and many women had to deliver without the partners. And this is a very sweet letter from the father of this baby that was born in April. And this is the first time that, and he was not allowed to be with his wife during labor. She has no phone, they could not communicate. And he was told that the mother and baby were well, and the next day he returns to the hospital to meet his child, and he waits outside and he writes this line. He finally was not allowed to see her that day either. And he wrote, like a white paper waiting for words to be written, here begins your life in our strange world. As the warrior you are, you have jumped your first hurdles. We will be here to support you and to thank you for the privilege of being witness to the miracle of life while sitting on the sidewalk waiting to meet you. So many men, many fathers have suffered also because of this separation and because of not being allowed in the delivery room. And it's important to be aware that having a companionship during labor, it's a human rights issue. Not only that, but there's a lot of evidence that proves that the role of the companionship during labor makes the birth smoother. So without a companion, there's a high risk of birth not going well. So it's dangerous. This is another birth story. I'm a big fan of birth stories, so I look for them all through the internet. This was a positive story, okay? Because this was a woman who had previously had a cesarean, and she wanted to go to the hospital to deliver her baby, but she didn't want to get there too early, as we see many women because of this fear of infection. So she finally gave birth in the car. It was an unassisted birth, but look at her joyous face, and she ended up having a very good experience. This is another story from Spain also. It's a woman, and she tells how she arrived, a mother, how she arrived to the hospital on April 7th after midnight. She had to go through the emergency room, and even they had told her that women in labor would have another entrance. When she got there, there was no another entrance, so she had to go through the same place. And at that moment, she had another toddler, so her husband had to stay with the older girl because there was no one else who could stay with her. So she said, I went into birth alone. It was a painful decision. Our girl was asleep in the car, and my partner did not want me to go in alone and carry my bag. I told him we couldn't leave our child alone. And because of confinement, they couldn't call other relatives. So she says, I put on my mask, my pink dishwashing gloves, grab my suitcase in one hand, my birth plan in the other, and walk away without looking back. It was one of the hardest moments of that night. I'm in labor, I yelled to the guy in admissions, who was not looking at me. Then he ran to get someone from triage. When I reached the hallway, I had a contraction and I had to brace myself on the wall. They opened the triage door and took me away on the wheelchair through empty corridors. In the labor room, I was examined and told I was dilated. I guess I must have been around 5 or 6. This was going to be fast. I gave them my birth plan and explained some of the things that were important for me. I had underlined in a bright color about the frozen pre-colostrum I had brought with me in case we were separated. They told me to go into the room and they would read it. In the labor room, I began to cry. They asked if it was because of the pain. No, it was not the pain. In the birth plan, I had written that the father would be allowed to watch the end of the birth by video call. I insisted and they said, don't worry. They offered to change my gloves for hospital ones, and I said yes. And anyway, so she says at that moment, I don't know at what point I lost the mask. For 7 hours, I labored and I was examined every 2-3 hours, but there was no progression because there was a bubble of water in front of the baby's head. And she says, I try impossible positions, whatever my body felt, kneeling on the bed, standing, squatting, kneeling on a pillow on the floor while leaning on a bed for leverage. And always there was someone from the team right on the floor with me, adopting even more difficult positions to support my monitor and help me. Vocalizations were useful at first, but then in the most painful ones, pressing my face against the mattress and paying attention to how the air passed through my noses is what helped the most. So finally, the midwife offered her the epidural, and at 4:30 they broke the bag, and she already started pushing. She says they asked me to take off my earrings, so this was real. They broke my waters. I was almost instantly fully dilated, and they asked me to push. I had no support for my legs, so I started to scream like crazy, and yet I could not do it. They told me it was better not to scream or I would lose the strength, and they took out the stirrups and handles for me to grab onto. This is a birth in a Spanish hospital, okay? Many places still like this. First push, and she crowned it. I felt the ring of fire. Second push, I felt her shoulders, and in the third, she came out and was placed on me. There was no video call. Circumstances did not allow it. It made me very sad. The dad spent the whole night with gadgets ready to watch and record, but it was not possible. They respected the basis of my birth plan all along, and they treated me very lovingly. They showed me her train with cord, a white cord before cutting it. No stitches, no cut. So she was born at 7:50, and she was happy, and the staff congratulated. And then, like 4 hours later, she asked for a voluntary medical leave. The obstetrician said yes, but the pediatrician said no. I had to stay 24 hours, and they told her that if she refused, they would call the judge because of the baby's rights, and that's very upsetting too. She says she understands, but we've seen more and more of this telling the women that if she does not accept, that there will be a court order for no good reason. So the second scenario that we might be seeing is women who do get infected during pregnancy and who do not have severe symptoms. What happens to these women? Well, some of them have fear of postpartum complications, and this is logic because we know some women who do not have severe symptoms might get much worse after delivery, and we've seen that. And some of them have higher risk of having thromboembolism, and so that's worrisome. But also we know that the women who are infected, some of them might have feel gratitude because they have been well taken care of. They might feel relief after the birth, and in some cases they might have early discharge and they might go home to isolate. But what happens? How is the interaction in those cases? How is the postpartum? How are these women going to do? Um, some of them will feel very relieved, but then later on they will realize that some of the things went done to them were not all that necessary. This is another story about a woman who gave birth from Madrid, and she describes this situation. I arrived at the center with broken waters. Everything started. I was tested for COVID, and the result was positive at the moment she arrived at birth, okay? They did not test my husband, just simply not let him in. Also, I was giving an oxytocin drip to her at the birth, according to them, to expose me as little as possible. In general, the birth was horrible, totally the opposite of what I had prepared for. My baby was ripped out from me with forceps, and I got an episiotomy. But after the birth, the real nightmare began. He was tested, say so on the discharge papers, and was negative. But they still took him to the intensive care unit without even letting me touch him. I saw him from 2 meters away. I gave birth alone. No one was with me. I could not be with my baby, and I could not begin breastfeeding from the start. He was giving bottles without my consent, and now I'm having a lot of trouble to get breastfeeding going. So this is what we mean when we talk about mistreatment and obstetric violence, and this causes trauma. Okay, this is a traumatic birth experience. It's very different from this other woman. This story, I think, is from the United States. It's a story about a woman who ended up going alone because her husband was positive. She was positive too, but she went in with her doula, and she labored in a room with negative pressure, in an isolation room in the labor and delivery unit, with everyone caring for her and her baby. And during that time, she says how the pediatric provider on call had to provide information on why it was recommended mom and baby be separated at birth. But she said she declined and she just signed a waiver. And her husband was present for labor and delivery via FaceTime. And she labored in the tub and then moved to the bed. And she had an unmedicated birth, and she pushed her baby, Danielle, and this is the picture she shares. So it's very different to look at the difference and how the professionals can impact the birth experience by respecting the woman's need and wishes, even in these very difficult moments, okay? Now, probably the most delicate situation, but it's not the most frequent one, it's the most rare one, is the women who get serious infection during pregnancy and they require hospitalization in intensive care unit. Now, these women might have severe pneumonia in the third trimester, they might have pulmonary embolism, and they might be given medications as chloroquine that give negative side effects, psychiatric side effects, plus being in the intensive care unit. We know all this can cause delirium, confusion syndrome, and they might not even know where they are. And we've seen of women that when they were admitted to intensive care unit, it was decided to terminate the pregnancy prematurely or not, because to relieve their suffering and the distress of the pneumonia. But some of these women have been waking up without even knowing what has been happening. And this is a lot of trauma as well. The reunion with the baby, plus some of these women who've been severely ill might take days or weeks to get better. And some of them might have the post-intensive care unit syndrome and a high risk of thromboembolism. So this is going to be a slow recovery. There are many issues, but we still don't know. As I said, these are rare cases, but they're still happening. And breastfeeding might be very difficult. Although we've heard some very nice stories of nurses who've been caring for these women, these mothers in the intensive care unit after giving birth, intubated, and they have helped them release the milk from their breasts so they could give that milk to the baby that was hospitalized in the maternity ward or some on the pediatric ward, and they have helped some of these women to start breastfeeding once they have been reunited with the baby. So that's always a possibility. So we also have to think about the consequences of all this stress for the baby in the uterus. Okay, this is a paper that summarizes the psychological stress during pregnancy and the risk of the neurodevelopmental disorders in the offspring. We know that if the mother has anxiety and stress, and this might be toxic, but also we know if the mother has pneumonia or other complications of COVID, this can also cause preterm birth or hypoxia on the baby. And if the birth is induced or it's by cesarean or if there is neonatal separation, this might have long-term consequences on the infant mental health, on the breastfeeding, on the attachment relationship. So how do we move on from here? Many of these babies have been separated, sometimes for no good reason. We know the longer the separation, the more traumatic it is, the more damage is going to cause. And we know the breastfeeding might be difficult. And we also have to think, with all we know about the infant development, how is going to be the social interaction when the mother or the caregiver has a mask? How are they going to create their attachment relationship? We are a bit worried about this too, about the consequences of all of this on the infant mental health. So let's get into the second part, is how do we deal with this? How do we manage all these types of birth trauma? I try to give you a model that we work with, okay? As I said, it's an ecosystemic approach. We first have to develop the trauma map, and this is very important. We have to know what happened, and I will get into this. And then with that, we're going to help the woman and her family to create a narrative for their trauma, and that's totally necessary to heal the trauma. We have to have a narrative. We have to know what happened, and it's important to have access to clinical records and to keep a diary. And with all of these, we will do a management plan. Okay, the management plan, we'll see there's different layers, and we might help different things at different moments in the postpartum or even in the year that follows the birth. Okay, first, as I say, it's important to draw this map. The birth story. The first thing we can do for a mother who's giving birth, who had a traumatic birth, is listen to her, and empathic listening. That always helps heal. Birth can be such a intense experience that all women need time to integrate the experience, and we integrate the birth experience by narrating it. And women, there's research that's seen that all around the world, recent mothers need to share their birth stories many times, and every time they share it, they catch a detail of it. It's like putting the pieces of the jigsaw together, building the puzzle. So we can offer the woman, tell me your birth story, tell me how it all went. Tell me, I'm here to listen. I can sit here for half an hour, but it's very important. And it's very important also to listen the story of the father, okay, what he experienced, and help them listen to each other, because sometimes things have been such a rough stress that they haven't even had the time to listen to each other, okay? And maybe the father is also traumatized by what he experienced. So it's very important to get this birth story and help the woman write it. And sometimes writing a birth story might take weeks, months, even years, but it's a very important step towards recovery, okay? Because once we have the birth story written in great detail or recorded, then we can identify all the traumas and losses there have been. And there are all these layers I want to work with. First, the physical trauma. It might be there. There might be physical trauma. It's very common. Maybe the mother had a cesarean. Maybe she had an episiotomy. Maybe she had a tear. All of these sometimes leave physical problems that not everybody gets support for that. Some women might have incontinency after giving birth, or they might have pain in their scars, or they might have adherences, and they might have a keloid scar. So it's important to see how this, or they might have sore nipples with crackles, and it's very important to get support for that. And some women will need to go to a pelvic floor specialist, a physiotherapist that helps her healing that, okay? And then we have to do the psychological report. We have to see all the symptoms that the woman might have of traumatic birth. And there might be PTSD symptoms, but usually we only see some of those symptoms, okay? We have to help the woman identify the symptoms. Does she have flashbacks of the birth? Does she have nightmares? How does she feel when she remembers the birth? Does she have intrusive memories of the birth? Has she had panic attacks? Does everything she sees remind her of the trauma? Is she continuously thinking about what she could have done differently? And there are many symptoms of traumatic birth, okay? We go through this on the course. But it's important to see how each of these symptoms impacts the mother, okay? How is this affecting her social interaction? Is this affecting her relationship with care providers? How is this affecting bonding with the baby? And how is this affecting the baby? What did the baby experience in this birth? What was the experience like for the newborn? Who was he or she with? So we have to know all this. How is this affecting breastfeeding? What's the impact? How is this affecting the relationship with the partner? We know traumatic birth, when there is PTSD symptoms, sometimes there's a lot of anger, and it's very important to name it and to work through it, okay? And there might be disappointment, and there might be fear still, or there might be fear. Mothers might be worried about the consequences all of this will have on the infant development, okay? And how is this going to affect her identity? And some women do have, because of this trauma, they might have many issues with their own identity as mothers. Some mothers will feel broken because they didn't have the birth they had dreamed of. They might have a professional crisis, and some of them will even change their professions or become doulas after, or a spiritual crisis. So it's very important. And with all of this, we're going to draw a map. And for each one of these, we should offer a different therapeutic approach. I will get into that now. But we also have to be aware that the beauty of this is that there can be post-traumatic growth. And going through trauma, once birth has been traumatic, if we get containment in the afterwards, if we can work through these issues, many women come out with a feeling of growth, personal growth, and that's beautiful to watch, okay? So the narration of the trauma is important. As I said, we need to help the woman to construct her story. to create the narrative. And in some cases, the woman might need access to her clinical records, and she might need to discuss the clinical records with the midwife, with the obstetrician, with the therapist, with whoever was there, okay? And then some women might need it might help to create a diary, and sometimes if the mother is in the intensive care unit or the baby is in the intensive care unit, it might be very helpful if someone else in the family keeps this diary to tell the baby when they grow up, okay? This is a news from a Spanish hospital. It's the first twins that were born during the pandemic through vaginal birth, and the parents were saying this. We will tell them that the birth was like a movie birth, okay? So it's very important when the woman writes and tells us her story, it's very important to validate her experience, okay? If she has feelings of horror, of not having been supported, if she feels she was mistreated, it's very important that we validate her experience. And then maybe we have a chance to listen to the experience of the professional. And the professional who was there was also traumatized, because it was a very difficult, traumatic situation in very difficult circumstances, okay? Our role as therapists is not to judge anyone, but to help them heal, to support. So as I say, for each sphere, we will make a plan. And this has to be individualized. And we have to prioritize according to the woman's wishes and her needs and the needs of the diet. And maybe some women will say, well, now the only thing I want is make sure breastfeeding works. Fine, get good breastfeeding support. Or maybe what's more urgent for me now is that someone helps me with the tear I have from birth. And maybe you need a pelvic floor consultant. And maybe I know I'm traumatized and I need psychotherapy, but because I had previous traumas, I don't want to get into that now. And maybe I leave my psychotherapy for further down the road. And now I just want to focus on working on the interaction with my baby, because this is a very precious time. Okay, so it depends. But it's important to know when do we need an urgent psychiatric consultation. Okay, be very aware. If the woman has severe insomnia, if the woman seems confused, if she starts saying things that are bizarre or incoherent, be aware that she might be starting a postpartum psychosis. This is a very uncommon disease, but very severe. With proper care, it can be treated and solved, but without care, things can get really difficult. Okay, so if you see if you are with a woman postpartum and she starts to act bizarre or seems very confused, please don't leave her alone and go to the emergency room and get a medical and psychiatric consultation. And then there are things that help. Of course, there's always things that help. That really help are practical support, help with the house chores, help rest, and this is also difficult nowadays with the confinement and the isolation, so we have to be creative. This is another birth story about a mother in Spain, near Madrid. She says, my birth was good, just a few stitches, like with my previous child, everything was okay. Physically, I was well, but psychologically, I was very sad. I went to my room in the general hospital alone and isolated. I knew nothing about my baby. First time I saw him was 12 hours after birth, thanks to the nice NICU personnel who showed him to me in a video call. Following my primary care midwife's advice, I began to express milk just like if my baby had been with me, like if he were breastfeeding. I used hand expression and then pump when it was flowing. I also took breaks to rest. It's important to rest, especially if you're sad. After a lot of pressure and talking to the doctors, I was discharged 24 hours after birth, but we had to wait 24 more hours until our baby was discharged and finally got home. For the first 40 hours, my son's life, I could not even see him. So this is very traumatic for many women. And this mother says, I'm happy because we have achieved natural breastfeeding. I spent 48 hours without him. When there is lack of scientific evidence, that's a protocol that separates mother and infants after birth, only for them to go home together 48 hours later with a recommendation to breastfeed because it's good for its immune system. Make any sense? And she asks this, no? I think this is a very valid question. Can a protocol that forgets the physiological relationship between mother and newborn be called humane? So this is a good advice from a colleague. Esther Ramirez Matos is a psychologist, and she wrote this piece about postpartum in times of panic, and she offers very good advice that I want to share. She says, if you have recently given birth and are caring for your newborn day and night with little support, care for yourself too. You're protecting yourself and your family by staying home, but also have a care with what comes into your home. News, text, messages, audio, social media conversations. Choose to tune out what distresses you and tune into what gives you strength and energy. I know it is heroic in these times to be fearless, but remember how fortunate are that you and your baby can cuddle and give each other the gift of oxytocin, the hormone of love and bonding and calm. If you can, enjoy this time. Don't get lost in the internet and the statistics. Really isolate yourself from the outside world. Live in your own slow, calm, bonding, mothering time. Dear postpartum mother, I wish with all my heart you can achieve this, that you can build your own world with your baby inside your bubble, in your warm little den. This intimate space you can build with your infant's help can protect you both from the dark surroundings. Do not feel guilty about desire to do so. Postpartum is not a time for battle. It should be a time of well-being, of enjoying your hard-earned, beautiful postpartum, a time of mothering with pleasure, to lessen the print of these scary times we are forced to live by kissing, holding, hugging, feeding, loving your baby, and being together hours on end. How nice. So how do we treat the birth, the traumatic birth on the infant side? We also have to make a plan, a management plan for the baby. And there are very interesting works with infant psychotherapy. I recommend you these books by Alice Lieberman and on repairing the effects of stress and trauma on early attachment, and also this work by Miriam Cesar about talking to babies. I think it's very important to provide trauma sensitive care for the infants, okay? And it's important to remember newborns and babies listen, understand, feel, react, love, give. So I think the first thing when we relate to these newborns and to these babies is to tell them, I see you, I know who you are and where you come from, to observe them, to listen, to explain things that are going to be done to them, to give them time. You know, the time of the babies is a different time. It's very precious and very slow. And we have to be present to heal, okay? So what about the last line about healthcare providers? As I already said, some of them are also traumatized and also need care. And I know I want to share these words by a midwife from Argentina. She wrote this after knowing she had served for a woman who was COVID positive. And she says, everyone in obstetrics knows that physical distance is almost impossible in our job during labor. Hold the hand, massage, support, breathing, relax, be attentive to the woman's needs as they change. She says, when she found out she had been with this COVID positive mother, I think I did not give in too much to the negative thoughts that assailed me during this situation, but it is inevitable to think about getting infected and the consequences. Doubt and fear are unwanted visitors. Personally, I try to focus on doing everything possible to achieve a happy, positive birth experience, and that is what gives me peace. I'm now in the last days of my confinement. Fortunately, have no symptoms, and I conclude that things done out of love are worthwhile beyond our profession or the results. Let's not let the fear of this pandemic snuff out the light of birth, an unique, irreparable moment for each family. Let's not forget love and empathy. So to finish this class, I want to share these basic ideas. What heals most is love. Healing and growth can always happen, no matter how bad the trauma is. We can always heal and grow out of it. And I wrote this piece. It was called Oxytocin versus Coronavirus. You can read it on that site. And I think it's very important. We promote oxytocin and we promote love to heal and trust in this context. There are some interesting resources. There are birth trauma associations. We also have some in Spain. There's ICANN, International Cesarean Awareness Network, and there are many others. I didn't do an extensive list. There's this cost action funded by the European Union on research on birth-related trauma to maximize best practices and optimal outcomes. And we also have this Spanish support group, Mama Importa. And I want you to invite all of you to continue seeing us at the European Institute of Perinatal Mental Health. Most of our teaching is in Spanish, but we do have this one in English on the psychology and neuroscience of breastfeeding. And I wish you all the best. I wish we can all come out of this crisis with open hearts and moving into a more oxytocinergic society and with a better care for mothers and babies and families. Thank you.